And the reason is, of course, that because of the partial compensation function of the epithelium, you often need to do multiple procedures because you're making that gap smaller. That ETR is smaller each time you go in. And to go and illustrate this beautifully is this case that I showed earlier of the hyperopic treatment that was done 2 millimeters off center inferiorly. The patient pre-op was just a plus 150 treatment. It was supposed to be a nice little, monovision procedure. Fortunately, it was only done in one eye because the other eye wasn't treated after it was noted that things weren't quite right. The surgeon did take his foot off the pedal before the end of the treatment. So he was treating plus 375. 6 months post-op, the refraction was plus 4 minus 225, but the best corrected was only 2063. And of course, as I showed you earlier, the epithelium showed this lovely donut pattern, but unfortunately 2 millimeters below where it should have been. So there's the decentered hyperopic ablation. Now, our transepithelial PTK model for the first procedure, going down 49 microns to breakthrough 52, 55, 58 microns, was performed, and this is what we achieved. It was plus 4 minus 225 at 75, best corrected 2063, and post-op plus 350 minus 1, best corrected 2040. So there's a little bit of an improvement, but you can see the change map, and you can see how in the center the epithelium was so deep that we actually didn't, because we weren't taking much tissue out from that area, we didn't manage to actually change the situation enough. And so a second procedure was performed a year later, and as you can see here, the plan was to go down to 70 microns, and here's the pre-op epithelial profile, and here's the post-op epithelial profile. The refraction, as you see, plus 350 minus 1 to plus 350 minus 0.75. So the refraction again didn't change, just PTK, but the epithelium is now far more regular after this procedure. There's one little dimple here that was still filled in. And now the best corrected visual acuity was back to 20/20. Coincidentally, so was the epithelial thickness profile. It was much more normal looking. And so at that point, we created a flap with Visumax, aiming to go 2 standard deviations below the thickest epithelium to not create a buttonhole, which we did. We targeted minus 175 and unfortunately ended up with a big undercorrection, which I can only explain by thinking that the epithelial thickness profile was already wrong. It wasn't like a primary procedure. In other words, the epithelium was already thinner in the center of the cornea. So the power of the epithelial contact lens on the stroma was different than the power of our epithelium sitting on our stroma before surgery. And that epithelial contact lens is the error of my treatment. I should have known better, right? As someone who has the machinery. Anyway, he ended up undercorrected, but very happy because now he has perfect vision through his plus 125 minus a quarter glasses. And remember, he started plus 4 minus 2 at best corrected 2063. So he was actually a happy camper, and I did offer an enhancement to him, but he said he is as happy as can be. He's better off than he was when he started, and he didn't want another treatment. I was glad he said that. But I would have been delighted. Yes?
Why did you wait 1 year to do this?
We wait 1 year because we wait until there is no change in refraction between one time point and 2 months later. If there's a quarter diopter change, and we have a very standardized refraction protocol in the clinics, it's like a computer program. You do this, you do this, you do this, you do this. So you reduce the inaccuracy of the refraction. We want absolute stability so that we're not shooting on a moving target. But you're right. If you're doing multiple transepithelial procedures, it doesn't matter what the refraction goes to. You can just go in and do one after the other. And actually, I'm going to You've been to this course before. No, I'm just kidding. Because this is not, I never showed this before. This is new. But this is exactly, it's good. It's good. So, but I'm coming to an example where you don't have to wait. Yeah? As Tim showed, an analysis of our cases over the years that we've done has shown that there is a thinnest epithelium that we've observed in all these cases that we've analyzed. There's a thickest part of the thinnest, and there is a thinnest part of the thickest cases. So the population maximum of the thinnest point is 54, and the population minimum of the thickest epithelium is 60. So hang on, there's more to come on that slide, so take a picture when it's all there. And I say, by the way, I should have said this right at the beginning, because I noticed that people had to leave, or they didn't like the course. But if you would like a printout of all these slides, please leave your email address with one of us at the end of the course, and we will email you the full, all the slides. You can have them yourself. We will, not promising when, but we've recorded the sound on this course, so we will marry it to the slides and create a video of it, which we will put online. So if you want to watch that on YouTube or something, then please leave your email address with us, and we will distribute the course to you if you want to go over any of this again. But please do it. Anyhow, so population minimum minute. So what we're saying is this is exactly what you were asking. You don't have a machine. Well, what's the worst case scenario? What's the best case scenario? And so we do have a window here between 54 and 60 microns, which means that we have a way of making a suggestion where you can't go wrong effectively. You're unlikely to go wrong. And so if we think about, if we think about this 51 micron, this is the thinnest part of the biggest group, and the biggest one, and we think about all of that tissue that window that you can take advantage of through our experience just statistically. What we're saying is that if you plan a 55 micron depth ablation without knowing anything, you're going to make the patient better, and you're highly unlikely to waste tissue. Okay? Now, when I say 55, I mean actual 55. So for us, it means multiplying our laser readout by 1.3, right? So you want to take out 100, you got to put in 130, or 55, you got to put in 68, or whatever the number is, okay? You do that thing in your head there. 75. No. 60, yeah. 68.
Yeah, 68.
Jesus. Listen to my intuition first. So 55 is the answer. Now, your laser readout may not be correct. It may just be Munrelin. The company puts it in, the CE people mark it, CE marked, they didn't check it. So you may not know. So you may be slightly off. The point is you'll be undercorrecting. And I think it would be safe to say, because we have calibrated the ablation depth of the ML80, and we published that. So we know that the ablation rate is 1.3 times low. You have to multiply the stromal ablation rate by 1.3 to get epithelial ablation rate. So 55 microns. And then what we would suggest you could do, and this is your judgment, is that you do your 55, just don't stop, just hit the pedal and go all the way down 55. Stop and look at the breakthrough pattern. And think, I haven't really got very far here. It's a lot less than you expected. The bump hasn't even been exposed. Okay, then it would be safe, very safe, if you went in 10 micron steps at that point, judging whether you've exposed the irregularity enough to have ablated a significant amount of it. 10 micron steps is a safe thing. Always better to stop and come back another day than to do too much, because you can't put tissue back. Okay, so I always have like a rule in my head that I was taught by my teacher, Hugo Sutton. He says, always do 2/3 of what you think you should do. And that those words just sort of come into my mind when I'm doing one of these regrets. I'm like, I'm going to do some more. Always do 2/3 of what you think you should do. It sort of comes into you like that. Let me show you a great example of this. A patient had a -5 sphere treatment with a NIDEC, and for some unusual, bizarre reason, the enhancement produced a massive central island. We don't have notes. We don't know whether it was because they put a presbyopic profile on or they moved a Q slider on a wave ladder. We don't know what the hell happened, but this is how he presented. And let's be clear, this is considered by some to be a presbyopic treatment. I'm not one of them. I think that's a bad thing. The patient certainly didn't like it. And so what we did was look at the diameter of that and look at our epithelial thickness map, which of course you get the thinner epithelium over that bump and thickening around the periphery, as expected. And here are the B scans. You can see on this vertical scan here, very, very clearly, you can see how there's a bump in the stroma in the middle. Yeah, it's very nicely delineated there. And what we did was a simulation as a first ablation. And so there's the simulated amount of tissue that was going to be removed. And there's our endpoint once we removed everything. And you can see pre-op, there are a little bump, and post-op, you can see how it's got dark here. That's because we've ablated Bowman's. And Bowman's reflects. So you can see we have literally selectively removed that bump and Bowman's and a bit of stroma from that location. Yeah? And so this was actually a very successful treatment. Here's the pre-op map, post-op on the same scale, and here's the change map, and we had a happy patient with an outcome in one go. Now, for example, you don't have these measurements, so what do? Well, you would have we ended up going down to, let me go back to the slide here. We ended up going down to, is it 56 that we went down to? Yeah. But, which is kind of like what you would have done too. But let's say that we didn't plug in 56, you see, we plugged in 68.7. And you would have plugged in 55, and you would have got 2/3 of what you should have. So what you will then see in your microscope is this, or that, or that. You'll just see a little bit of breakthrough, and you go, geez, I'm definitely not far enough. The diameter of that island on the topography is 2 millimeters, and I broke through 0.2 millimeters. I'll put another 10 in. So, okay, you do another 10, measure the diameter, show the breakthrough. Another 10, measure the diameter of the breakthrough. Oh, we're at 1.5. All right. Another 10, measure the diameter. Oh, now we're at 2 millimeters. Ooh, I've exposed 2 millimeters. That means that I've removed quite a bit of stroma from the middle. I'm going to stop, and I'm going to come back in 3 months' time. And here's where you can repeat these things quite soon. Because, you're not treating the refraction here. You're trying to get rid of the bump that's causing very high order aberrations in the patient's vision. So you could, at 4 to 6 weeks, wait for the primary epithelial compensation to occur. Most of it is already there in 4 to 6 weeks. And then do another PTK, 55 first, 10 micron steps, stop, come back in 6 weeks, 55 microns, 10 micron steps, stop, until the topography looks acceptable, or the patient tells you he sees well. Because, of course, that's really the critical. So in summary, we're talking here about a subspecialty of our subspecialty. This is called sequential therapeutic corneal refractive surgery. And we've been through the ins and outs of wavefront guided ablation. We've learned that it only corrects about 30% of aberrations. It's most effective at removing spherical aberration, not coma. And if there's an angle kappa, don't do a wavefront guided ablation. We've learned about topography guided treatment, that it's way more effective than wavefront guided. The treatment is calculated based on the center of the topography, which is the visual axis, and topography guided systems, at least the Zeiss one, has the ability for you to shift the tracker right onto the visual axis and treat everything about the visual axis. It's the best option for small optical zone, high spherical aberration, and decentration. The effect, of course, is limited by epithelial compensation, and this refractive effect, we hope in the future, will become something that is incorporated into our systems. But more importantly, for a take-home message, is you've learned a lot about transepithelial PTK. You've learned the law of epithelial thickness changes. You're going to walk out of here knowing that if you ever see any irregular astigmatism, that means the epithelium is irregular by definition. And so you may not be able to make a diagnosis because you don't have the epithelial map, but you know that there is a diagnosis that may not be the one that you're making by looking at the topography or the wavefront. And you know, therefore, that the best option for irregular astigmatism is not a topography-guided or wavefront-guided treatment. The best option is to start by PTK. And Tim has very kindly done a statistical analysis of our cases so that you can stay safe with some general rules, meaning 55 plus 10 plus 10 plus 10, etc. And do 2/3 of what you think you should have been doing, 2/3 of what you'd like to do when you're actually in the operating room, because you can always come back and take out more. Of course, you can proceed to topography-guided or wavefront-guided appropriately once you think that the irregularity has been pretty much compensated by small amounts of epithelial irregular changes. So with that, thank you very, very much for staying all the way to the end. Nadine Gobet, Glenn Karp, Tim Archer, myself, Dan Reinstein. Very important that you please take 2 minutes to fill out the evaluation forms with your badge number on it. That stops us from filling out forms for you saying that this was a great course, because we need your badge numbers. So could you please do that, because the size of this room was not sufficient this year, obviously. And also, please leave us your cards or emails or whatever you want so that we can send you a PDF of all these slides, and we can link you to this lecture, which will be online, recorded with the slides, with the animations, with everything live, hopefully in the not too distant future. We'll be here to answer questions if you want to come up.
Yeah, just a quick thing. I've never done this before, just an idea. Is it possible to remove the epithelium and then do...
That's probably Yeah, Pablo Michigera does that. You can remove the epithelium and then do a topography and then do a topography-guided treatment. However, as you can imagine, there are quite a few errors that could potentially be introduced by hydration, dehydration, differential hydration, dehydration, and the stromal surfaces can often be very irregular. So, when you put the drop of something on the cornea to get a topography, you're now masking the irregularity again. So, it's a great idea, but what we really want is we want companies to produce machines that measure that layer and does it properly in one go. And, my greatest incentive to them is that they will make more money, not because, of some kind of altruistic thing that we want to help our patients, but because more people will be confident in LASIK and there'll be more procedures. Which I think is the only way to talk to these people, that they just want to make money. We have our family obligations and our financial obligations, but we have our personal obligations to our patients, and it's an element that companies don't often understand about how we feel about our own complications. It makes us feel bad. Yes? No. Polishing with the wet is for things like microfolds and bits and bobs sticking out. So it's usually microfolds, and it's an extremely effective treatment. Paolo has I forgot the name of the substance, which has the same ablation rate of stroma, and he puts a drop of that on, and he whatever that liquid is, treats like a masking agent. I find that for microfolds, it's far more effective and easier to just flood the cornea and ablate until you can start getting breakthrough, stop, flood it again, and ablate, and dry it, and then check. And you saw in one go, It was like an eraser. It was like an iron, just going over the, yeah, yes. So with my laser, it's 6 seconds, because it's how long the surface tension of the liquid holds. Yeah, 6 seconds. So for us, it's 20 microns, because we're shooting at 250 hertz with a 0.7 millimeter spot. It does 20 microns in an 8 millimeter zone in 6 seconds. So that's why we program 20. But it's the amount of time that you have before the liquid surface tension breaks, because you don't want to start ablating stroma. You just want to ablate the little peaks that are sticking out of the water when the shock wave arrives.
Shoot the water.
You're shooting into the water, basically. You know, it looks like nothing's happening, and then you wipe and you go, whoa! Yeah, it's very surprising. It's like a magic trick.
How do you treat afterwards? I mean, mitomycin?
No. Oh, no. I'm glad you asked that. I never use mitomycin C unless there is haze. Yeah, I use it for haze. I don't use it to prevent haze. Why? Because development of haze is unbelievably rare with modern lasers. So I don't want to give it to 95% or 98% of people who wouldn't need it, just for the 5% who would need it, when I can give it to those people anyway a month later. So I check patients at 1 month, and that's when I decide if there's a bit of haze, to take them downstairs, do a 3 millimeter hole in the epithelium, soak the thing in, fluorescein without harming the epithelium goes into the anterior chamber. If you make a little 3 millimeter hole in the epithelium and put the sponge on for 2 minutes, trust me, that mitomycin's on the retina. So there's no confusion about that, and it works. So we use it if there is haze, not to prevent haze.
You have more rates of haze if it's on a post-lacing patient?
No. That was a paper which Carones published. Unfortunately, he was using a Summit laser doing PRK over LASIK, and the Summit laser itself was the reason why all that haze was being produced. We all know that you can do PRK on a flap absolutely safely with a modern laser that doesn't heat the surface very much. We do it all the time. I didn't even think about haze in that situation. Yeah.
Can you use fluorescein during the laser?
You know, I mistakenly examined a patient before taking them down once with fluorescein. And when the excimer laser was flying around, there was a hell of a lot of fluorescence because of the fluorescein. And to be honest, I got a bit scared because I thought, shit, that can't be a good, I don't know, it can't be, it sounds like a photochemical problem here. And there could be other effects. So the answer is, we need to ask a photochemical scientist, because I don't think that's a good idea, because it's obviously absorbing the ultraviolet light and bouncing off another, green light to you. I don't think it's a good idea. Or maybe it's a great idea, but I don't know why. Maybe it cross-links the cornea. I don't know. I have no idea. Maybe that's the new way of cross-linking, is you do the PRK with fluorescein on the cornea. Do we do anything to prevent haze? No, we don't put mitomycin. No, cooling, no. Well, yes. If we do a -8, then yes, of course, the first thing we do is put very, nice, cool BSS all over the cornea. But that's we do that with a +6 hyperopic LASIK. We do that because it's a minute of digging in the periphery, and that's a lot of heat. So we cool down the surface as soon as we can. But I wouldn't, But I philosophically think it's not necessary to use mitomycin unless there is development of haze, because so few patients develop haze that I think it's wrong to use it to prevent problems. It's just too uncommon. It's like cross-linking. I don't think it's right to cross-link every LASIK, because the number of people that are going to need it is 1 in 5,000. That's my opinion. I'd rather cross-link that one. Okay? Thank you.